Dear Chairman, ladies and gentlemen, first of all, a very warm welcome to everybody here in the audience. And first, I will briefly outline the possible indications for the use of new diagnostic roads in the field of real-time zone elastography, smart fusion technology, as well as fly-through technology. We have to skip this and to go on to abdominal and vascular imaging. There's a special focus on therapeutic options as well as aorta and carotid artery. And last but not least, some topics on breast imaging. Are there any guys in the audience who know the banana experience or banana imaging story? This is a new story. This is fishing experience. So all of you, you are very high educated expert. And so what's your diagnosis on this small object? Any idea? Okay, I'd like to show you this in real time. That's the case at the beginning of the experiment in real time. And of course, we need new technologies in terms of image fusion. On your left, CT and ultrasound. On your right, a very special artifact, which is named twinkling artifact, reconstruction of this small object. And we see this in real time. And look at this, very beautiful to see this twinkling artifact. Another technique, 4D, the same object. It's very well visible, and in the fly-through mode, we see very nice rendered image. We look into the eye, and of course, we have the possibility to do this in real time. This is the fishing experience, and at the end of the story, I will show you this in definitely real time. Oh, where's the fish? It's missing. Not really. Here's the fish, very nice, visible with this 4D fast technology. So we move on to abdominal and vascular imaging. And first idea is to have an idea of focal liver lesions under hyperthermia monitoring. And this is a method where we perfused metastasis with heated blood. And this is a new setting for melanoma metastasis, and this is the schema of the setting in a patient. And important for us is the information that we have a cannula in the hepatic artery and in the portal vein, and we have a perfusion of the liver. The hepatica in some experimental settings is claimed to keep the heated metastasis anoxic, and we used 40 degrees of Celsius over 60 minutes in this technique. And this is the situation of the patient before. We see an hypoechoic mass, an additional lesion, hypoechoic metastasis of a melanoma patient. We have a progressive disease. We see a lot of metastasis here and there and a progression in size. This is the situation of the acoustic structure quantification tool. And we see in the follow-up a big central necrosis, and it's very easy to detect with this new technology. This is the CT scan before, direct correlation to the high-resolution ultrasound, and once again, the progressive disease very well visible on this rim, and we see a lot of, oh, what's no? Problem with the technique? Okay, now we start once again with the same slices. No, not. So I will click forward, of course, really fast. Fishing experience, very nice. Not good for the beamer or for the technique here, but good for us in our daily routine. This is the fishing experience, and this is the very special case of the heated melanoma metastasis, where we see the progressive disease very nicely, the central necrosis in both ways, good correlation to the CT scan, and of course it's very important to show also the vascularity of a lesion. And you see here also a new mapping on this system where we can follow the perfusion of a lesion. There's a very, very fast inflow, a very fast arterial inflow, faster than the liver tissue. And if you look very careful on the lesion, you will see after 20 up to 25 seconds a fast washout in the lesion, which is very characteristic for metastasis. And of course, we are in a good situation to have a good correlation to the CT scan. And we see once again a typical washout in the portal venous phase. So this is the setting before the therapy starts. This is immediately after therapy, and we see there's only a portal venous phase spectrum here. There's a problem after therapy because we have here an occlusion of the arteria hepatica, a big problem here. This is the situation in correlation CT and ultrasound once again. Look at these images, better resolution on ultrasound, of course. And this is the value, the beneficial value of ultrasound. We see a complete absence of signal here in the metastasis, complete treated. We see a signal in the liver tissue as well in the portal venous phase. but the arteria hepatica is missing. And this is the situation in the angiography room, a re-intervention here. In that case, there was a dissection of the artery after therapy and a beautiful control based on contrast-enhanced ultrasound to have no contrast-induced nephropathy. This is another case of this topic. We see a good success of the therapy based on the PET scan here. And on your right, this is the situation immediately after the therapeutic option. We see a big central necrosis here. And after 1 month, a reduction of the central necrosis, the liver tissue become homogeneous. And of course, we can see also the hilum of the liver in this technology. This is a 4D contrast evaluation, especially of the hilum of the liver, to see what happens with the portal venous system as well as the arteria hepatica. As I told you before, this is a problem of this therapeutic option, and we see very beautiful here the central vessels. We see a complete filling of the liver in each scan plane, very nicely reconstructed. So this is another melanoma story where we see horrible situation based on the PET-CT scan. These are superficial metastases, and we see a hypervascularized lesion with a central necrosis, definitely better visualized for study reasons based on contrast-enhanced ultrasound with a new linear option. This is the situation 3 months later, and we see there's a very low vascularity index of this metastasis, and we don't have any contrast here in the lesion. So a good success of the therapeutic option. This is the metastasis before in the elastography, and we see a big rim sclerosis of this lesion and a softer central portion of the lesion after therapy. Of course, you can play with the analyses like time intensity curve measurements based on the raw data for follow-up of these patients. This is one helpful tool. And we see very clear here the perfused areas of the superficial lesion very nicely in this arrival time parametric imaging tool. And we see also the central necrosis in this example. This technology for fusion works also in terms of MRI scanning. On your left, MRI. On your right, high-resolution ultrasound. This is a round-shaped mass here, and this corresponds very well with this image. And you see here the impression of the bladder, very beautiful, reconstructed in the fly-through way, acoustic structure quantification, and there's the same tissue in that lesion like in the uterus. It's absolutely comparable, and that's the key for the diagnosis. We see it's an hypervascularized mass with a round-shaped. We see it's located near the urethra, and it's very well visible also in the live scanning mode. On your left, MRI scanning, this is the urethra, very well vascularized lesion. Here's the urethra. This was a Leiomyoma of the so-called ratio space, a very rare case. In a good follow-up situation, the MRI scan was performed 4 years before. Once again, a question to you. Is this an important phase, yes or not? Yes, of course, this is important because this is Freddie Mercury, and that's the problem with ultrasound. We can misinterpret images, so we need perfusion, not only in ultrasound, also in CT. And so we can see here, it's not a problem of perfusion on CT imaging. We have a nice image quality yet, especially with the new volumetric scanner generation. It's more a problem of contrast-induced nephropathy. And if you look at this scale, we see we have a high motility rate if you have an increase of the serum creatinine level of above 25%, and there's a great odds ratio between these collectives of patients, and so this is a high-risk situation if we deal with radiological contrast media. To overcome this limitation, we can use contrast media for ultrasound, and you see here a transplanted kidney where we see an infarction very clear, a peripheral hematoma, and this was a situation, a bleeding after a puncture procedure, and we look into the artery, the bleeding artery, in this virtual reconstruction of the same case. This is also a very interesting case where we see a pathological Doppler spectrum like that. And the question is, where is the hematoma located? Is this inside the kidney, outside the kidney? What's happened in that case? And if you play with contrast agents in the new generation with this new high-resolution ultrasound, we see very clearly the problem. This is a hematoma with a hard compression to the transplanted kidney. And if you look very, very careful, there is no bleeding here. But here's a focused area of an active bleeding, and if you look very careful on this video clip, we see a small fluid like that here. It's very well visible on a contrast scan, very easy to understand and to talk with your colleagues. Here we need an intervention, and there was a big compression of this hematoma. Also a very interesting case, if you look at a booklet for ultrasound and you talk on pyelonephritis, it's a very hot topic. And you see here that's a case where we see an irregular shaped cortex of a transplanted kidney. There's a perfusion defect on a very small nodule here, and the reason is this ascending inflammation based on the urethra with a thickening of the wall, and this is the urethra very, very well perfused on contrast-enhanced ultrasound, and this is the situation in real-time B-mode scanning. We see very beautiful here the urethra, then we skipped over the renal cortex, and we see a very inhomogeneous cortex, and this small nodule here, and that's the perfusion of the small nodule in the arrival time parametric map. And we see there's a delayed enhancement and an absence of vascularity here in that case, and also an effect on the capsula of this renal graft. And this is only visible with this new technology. And so we can say it takes 6.9 seconds to have contrast in this small nodule here. This is a small abscess in a kidney graft. So we are in the lucky situation that we can do a lot of things like kinking, like AV fistula, 4D scanning based on contrast. So in my opinion, this is a one-stop shopping situation for kidney grafts. New is that we can use linear transducer to evaluate the perfusion, and this works very nicely to see also the medullary perfusion, and this is a new tool and I think very nice for our daily routine. This is an interesting case of a so-called horseshoe kidney. Please first have a look at the images on your left. This is the CT scan before. We use the morphological information from the CT scan. Then we move on to ultrasound. We have the contrast available. And it takes only 9 seconds to have first contrast in the aorta, then contrast in the kidney. And then we see there is a slight vascular perfusion here of this bright septic areas of the cystic lesion. And of course, we can do follow-up. You see this mapping. There's more contrast in the septic areas. And this is the situation based from the fly-through experience where we can fly through the septic areas, and especially for the colleagues, for the urology department or the surgeons, it's much, much easier to understand this technology, to see there's a clear perfusion of these bright septic areas here in this complicated cyst of the classification of Bosniak grade 3. Another very interesting case, Stanford type B dissection of the aorta. Very well reconstructed. This is the flap here, this is the dissection. This is a stent in the arteria renalis, very nice reconstructed on this method. This is the scanning situation based from CT. This is the color-coded duplex ultrasound in the same scan plane like the CT, the power Doppler experience, as well as the 4D evaluation of this patient. And of course, it's a method for live scanning. So once again, morphological information on your left, CT. This is the stent in the renal aorta. This is the real-time image based on ultrasound, and now we have the perfusion available. It takes only a few seconds, then we see some turbulent flow here in the area of the stent graft. We see very nicely the dissection of the aorta, and now we have all scan planes available because this is a live image quality. We have the whole volume. We see the stent graft very beautiful. We see the flap very nice in the aorta, and then we can follow the aorta to the iliac bifurcation. And that's a procedure to have a follow-up in these patients, to overcome the limitation of contrast media application in CT, but to use the nice morphological overview based on CT. And you see here in the left iliac artery this big thrombosis or aneurysm, and the CT was done 2 years before, so there's no progression in this patient. A very good situation to stage this patient once again and to have a follow-up in this situation. What about carotid artery stenosis? So one major problem is that we have sometimes soft plaques in combination with a neoangiogenesis. And the new technologies, it's available to see this neovascularization. This is the resection of the plaque. This is a marker for endothelium cells. This is a marker for macrophage. And so we can say it's not a question of the occlusion or of the stenosis. It's also a functional analysis of the angiogenesis. And it's very important to find out the patients with a high risk for a plaque rupture if we see this neovascularization. So we can say this is very dangerous for the patient, and we look therefore very carefully. And this is a very nice image quality. This is inversion fly-through, contrast-based, and this is the same story like a CT scan. So now we mixed all things together, and you see you can turn around this plaque here, and we see very beautiful the stenosis or the high-grade stenosis here reconstructed based on this option. This works also for liver tips imaging. You see here some turbulent flow, but this is not the correct information. Sometimes it's hard to find the right scan angle for liver tips, and so it's much, much easier to use contrast, to invert the contrast, and to use fly-through mode to fly through the tips to see the stenosis, yes or not. This corresponds very well with these MRI scan. Good perfusion here in the tips. This is a big cystic lesion here. And last but not least, gold standard angiography, good correlation to the ultrasound results. Breast imaging, also a very hot topic. I think we have to integrate elastography in the Barrett's classification, especially to separate Barrett's 3 as well as grade 4 lesions. And this is an example how it works. This is a vibration elastography, which is named tissue Doppler imaging. And if we look very careful on this image, that's a clear lesion, that's clear, but here's a small nodule. And now you can analyze these small nodule based on strain ratio quantification, and we see there's a high value of strain ratio 4.31, and the meaning is this is suspicious. This is typically for a small satellite nodule, and of course this is an important information for the surgeon because now you have a greater lesion in size. This works very nice also in sensitivity and specificity. You see we have the highest sensitivity and specificity if we play with strain ratio in correlation to all other modalities. We use the cutoff value for this tool in a range of 2.27, and we had a very good agreement between both centers. This is an overview of the differentiation of focal breast lesions. Typical scan here, coronal view, retraction phenomenon, as well as this papillary cancer, which is very well reconstructed from the surface. This is an overview of a case of a family history of a breast cancer from the nipple to the axillary portion, 2 round-shaped lesions, and this is a typical situation of a lymph node metastasis. The family history case, once again, coronal view, irregular shaped mass, the vibration elastography, no vibration inside the tumor, and the typical compression elastography, which shows us a very stiff area, so it's easy to understand that lesion is malignant. What about microcalcification? It works also very nicely for microcalcification scanning. You see here this is an experimental setting of small biopsies and the correlation to the vacuum biopsy or digital mammography, and we see clustered microcalcification in different mappings. And we use this, of course, also for the patient situation. And the trick is here to use a so-called false alarm ratio filter. And you see here we can summarize this information of these small microcalcification because we have a very high impedance level here on this very small calcification. And this is the patient situation, B-mode scanning, calcifications, stiff area, nice B-mode quality, and of course this is a suspicious area. Once again, the case with familial history of breast cancer. Look at this. This is a round-shaped mass. In my opinion, very well comparable with a fibroadenoma, but we see some calcifications in the surrounding tissue. We see a very high vascularity index, and we see a stiff area. This is the coronal view. We see very beautiful here the microcalcifications too, and we see a slight retraction phenomenon. And I want to show you once again the vascularity index, which is very typical here for a malignant lesion, where we see in the border this typical feeding artery, very well visible in the live scanning in correlation to the vascularity index. This is an intracystic lesion, where we see beautiful the surface, irregular surface. This is a stiff lesion. We have small microcalcification in the central portion of this lesion. This is an irregular lesion, very inhomogeneous, and so this is highly suspicious, and this is an intracystic carcinoma. A short outlook, in my opinion, it's very good to have different departments in your boat, and I will show you the Department of Urology, because now we are one center and work very strong together. This is an example of a stiff nodule, which is hypoechoic in the ultrasound scan. And if we use contrast-enhanced ultrasound in the arrival time parametric mapping, we see a very well vascularized tumor here, and this is of course high suspicious. We can use 4D application. We see the tumor once again with a very high resolution, nice reconstructed. And so if we have all these new features, we can say, if we look or if we play with the literature from the year 2011, we can say contrast-enhanced ultrasound have a sensitivity in a range of 73 up to 81%, elastography in a bright range from 51 to 92%, and also color-coded duplex ultrasound, especially in combination with contrast, has a value. And this was our first study to this topic, where we see contrast-enhanced ultrasound in combination with broadband Doppler, especially hypervascularized lesions with a high Gleason score are very well detectable, so that we have a higher detection range in a range of 10%. But I think we need new ways. One new way is this, target-specific contrast-enhanced ultrasound, to use ultrasound as a molecular tool. This is a red prostate, 2 millimeters in size, and we see very nicely the perfusion here, once again in this tool, arrival time parametric imaging, to see targeting bubbles only in the tumor, very nice visible in my opinion. This is the image quality today, and you see a very nice resolution in B mode. In the typical situation, peripheral zone, hypoechoic mass, a stiff area, very well depicted on this technology. Contrast of this lesion, asymmetric contrast enhancement, which is very typical after 42 seconds here in that case. This is the corresponding MRI image, T2 weighted image, the same tumor in the fusion mode, very well visible. This is the same tumor in the 4D story. We have a volume here of 0.36 milliliters, very nice visible with a very high quality and resolution. And this is the live scanning mode, and that's the way how we play with this method. You see here on your left, this is a typical situation in the MRI scan. The peripheral zone has a hyper-intense signal. The small tumor is hypo-intense. And first we fixed the target lesion. We fixed this tumor like that. We find the right scan plane based on the morphological overview on MRI now, and we fix the tumor, and then we move on to the ultrasound scan on your right, and you see very beautiful this hypoechoic small mass. It's very well visible on this technology. And that's the idea for prostate cancer detection. If you have a very high PSA level or a positive finding in a digital rectal examination, of course you have to perform a randomized or standard biopsy based on transrectal ultrasound. In my opinion, it's very useful to use elastography too, because it's not time consuming and you have no additional costs. If you have a negative biopsy and you have, once again, an increase of the PSA level, you can perform a free Tesla MRI scan without an endorectal coil. And that's a good idea. If there is no problem, you have to be in a controlled situation. If there is a problem, you can use this for fusion biopsy based on ultrasound. And last but not least, hopefully for the future, we have a higher detection rate, and it's better for prostate cancer detection. So therefore, I have to say thank you so much. And I'd like to show you the final end of the fishing experience. And sorry for the server, but I think it's no problem. Now you are not hungry, and that's a real fishing experience, and I have to say thank you so much for your kind attention.